grateful to be here. And I know many of my colleagues from Samuels are on the line. So shout out to Samuels. Thank you for joining us. I'm going to go ahead and get started. Oops, I'm going to go ahead and get started with our learning objectives, which is to analyze the epidemiology and the trends of HIV transmission, specifically thinking about risk factors to women. We want to then move into identifying and addressing barriers to PrEP uptake among transgender and cisgender women, thinking about the medical, social, and structural concerns. And then lastly, we want to talk about current and emerging PrEP therapeutics and regimens that are optimal for HIV prevention in women. And I just want to note here that unless I'm specifying, we are using women to cover all those who identify as women. And there are many places where we do specify because a lot of the studies do reflect the kind of need to be specific, but I really want to make sure that that is understood as I'm speaking. So the story of HIV is a story that is deeply tragic, but also very inspiring. And I think if it's told in the frame of the then and the now, we can see how far we've come and how far we still have to go. And this is a famous picture by Tom Fox of a family mourning the passing of their loved one in 1989. And it I think captures the collective grief of a generation over the losses suffered from AIDS and HIV. And the early focus of the epidemic, as when and if it brought in women, was really in this discussion of women as vectors of disease, right? And so the terms that were used that we don't employ now, mother to child transmission or vertical transmission, we use vertical transmission, but the mother to child transmission kind of framing that really focused on and kind of created this image of innocent children getting HIV from women. And women were focused on as a conduit for the passage of disease. And that happened, I think, in the way that research was described, and the way that promotional work around advertising who was at risk for HIV was described. And I think that a lot of that impacts the way that HIV is framed among women now, and the way that it's discussed among women now. The story of HIV was really turned around, as we know, in 1996 with the introduction of highly active antiretrovirals. And even with that story being told, you can take a look at these graph lines coming down significantly in 1996. You can see that it differs by different racial and ethnic groups, and that those differences persisted even as things got better and better. And so for Black communities in particular, and I'll kind of focus on that as an example because the rates are so high, you can see that they were still more likely to be infected and to die from AIDS complications than their white counterparts. And that was true for men and women, right? And so the trend kind of was there before, and it carried through. And so what's happening now? Now there is, in a lot of ways, so much to celebrate. And I think many of you who are on the line remember this and remember the old days and can really look at now and think like, wow, how better things have got. Overall, the incidence is decreasing, or it was until we've hit the current time that we're in with HR 1. And it's significant, 31,000 new infections in 2018 to 36,000, excuse me, to 31. There was really this goal as we are tracking these numbers in this way, aligned with ending the epidemic, ending the spread of new infections, and really treating those who are currently infected with HIV. And so I note that the decrease in incidence is happening, and I also note that that story in the last couple of years may change. So what does it look like, and why do we kind of focus on subgroups when we talk about HIV? Because if I've told you that the story was really sad in the beginning and it's gotten, better overall, it does matter for us to understand what's happening at a kind of digging one layer deeper. So the story of HIV is always really interesting if you tell it with different lenses. So putting on the lens of what's happening among racial and ethnic groups. Now, looking at these 2023 statistics, Black Americans make up between 12 to 14% of the population, and yet account for almost 40% of HIV diagnoses, right? And that's compared to 60% of white Americans by population versus 23%. So there's something happening here. If you look at women, it's even higher. So Black women accounting for 13% of the population and somehow accounting for almost 50% of new infections. And so there is deeper understanding than and I think a different lens that has to be placed to understand what's happening with this epidemic among certain groups. In general, it makes sense. We've talked about HIV as a disease of men and men who have sex with men, given the kind of just this graphic that shows you the difference of the numbers. And this is looking at data from 2017 to 2021, looking at HIV incidence among men versus women. And the mode of transmission at a national level, we know and we have known is different. There's a lot more accounting for same-sex couples and injection drug use, whereas with women, it's much more injection drug use and heterosexual contact. And we'll see those numbers for New York State specifically in a moment. When we look at transgender individuals, the numbers are much higher again for minoritized groups. And what's boxed off here are the numbers for transgender men and transgender women. And you can see Black Americans and American Indian Alaskan Natives represent a much higher percentage of those who tend to be impacted by HIV. The story of HIV historically has been one of a story of the coasts. And so the first few infections were found in New York and San Francisco, and the stories that we've historically told have been what's happened in those communities. The story of HIV now is very interesting because it's really become more of a story of what's happening in the South. And for those of us who follow health policy and think about, public health, it's really unfortunate because some of the southern areas are also the areas that have some of the least resourcing and some of the least public health I would say, advanced public health agenda to really address the fact that almost 50% of new HIV infections are coming from the South. And if you scroll down and really look at those numbers, looking at Louisiana, Mississippi, Georgia, Florida, there are parts of Florida and Miami that really mimic parts of sub-Saharan Africa. And so what I'm attracting your eye to is the darker green color that you're seeing there. And so, yes, it's an issue across, the whole United States. It's particularly an issue in the South. I wanted to give you this high level view because when I go into talking about women, in particular, I want us to have a real sense of the why this group is particularly important to focus on if we're invested in really taking prevention to the next level. Women account for about 30% statewide of those living with HIV and AIDS, and about 20% of those who are newly infected. And the kind of story of HIV in New York City has been one that's been very positive overall, in that the all-cause mortality that's HIV related has continued to go down. Excuse me, the HIV related mortality has continued to go down, and all-cause mortality, non-HIV conditions has actually increased, which is what we want to see because it tells us that the ways in which individuals are being brought into care and cared for is appropriate. And yet, the differences that I described to you nationally are even more stark in New York. Black men are 5 times more likely to be infected with HIV, and women are up to 2 to 17 times more likely compared to which group you're looking at. And here, I think it's very important for us to think, as many of us who are providers, what the transmission looks like, right? Because among men, who again we tend to really cater the conversations to, etc., it's same gender couples, right? It's men who have sex with men that's predominantly driving the transmission risk. For women, it's heterosexual contact, which again, individuals may not consider themselves to be at high risk in those cases. And so the ways in which we're reaching people, the ways in which we're talking to folks really, really matters. I want to bring in another layer, and I hope you kind of have seen this coming about social determinants of health and ultimately structural determinants of health, because the stories that we're telling around this, something else is going on, right? We no longer believe in a biological reality for a propensity to disease. So it's not like, Latino people and Black people are getting HIV more because of something biological. We understand that there's something social happening. And one of the beautiful things about the New York City Department of Health that they do is they'll do these maps by zip code and kind of just let you map on different things by different characteristics. And so on the left side in purple, you're seeing the area-based poverty levels by zip code. And then I want you to kind of map that over to the HIV diagnosis per 100,000 individuals. And the darker orange is where that tends to be high. And you can really see in parts of Brooklyn, in parts of the Bronx, where the poverty is medium to high or very high. Those are some of the things that are also driving HIV rates as well. And so it really leads us to this place of thinking, okay, well, there's work to be done. There's certainly work to be done for all groups, for racial and ethnic groups. And I want to hone in particularly on women, because as I've said, historically, women have been spoken about as vessels of disease and not necessarily kind of specifically looked at. We know, and you can look at this graphic to kind of summarize it, HIV among women is a disease that affects certain racial and ethnic groups more. It's a disease of young people, and it's a disease that's really, really spreading quite rapidly in the South. And if we're serious about ending the epidemic, which that is a question given where our public health in our country is going, but if that remains a focus, focusing on women is a really, really significant way to do this. You can see the proportions of the epidemiology that are accounted for by women, specifically certain socioeconomic and racial and ethnic groups. And so this becomes a particularly interesting question as we start to go into it of what preventative sources are available for people who identify as women, because a lot of the studies that were done historically didn't necessarily include women. And so, how do we extrapolate and understand the therapeutics that are available to do good prevention work? And that's why it's worth spending the time to kind of go back and really look into what's available for us to understand how we do our clinical decision making.